Thank you. Thank you very much. Thank you, Mr. Chairman, for your kind introduction. And good morning. It's very early good morning for me in Birmingham. Sorry I couldn't be there. I would like to thank the organizers for the kind invite. Today, the topic I've been given is talking about GLP and GIP, whether injectables and orals. As we know, this is probably one of the most fascinating areas of development in terms of both managing type 2 diabetes and also more and more in terms of managing obesity. Recently, I was reading that now tirzepatide or Manjaro has become one of the largest prescribing medication in the world. Now, this brings more attention to these agents because a lot of patients, Muslim patients who will be fasting in Ramadan, will be on these medications and will be coming to us for advice. So, what I'm going to be talking about today is looking at the rationale for GLP-1 fasting. We have been enrolled in this research on GLP-1s in fasting about 10 or 12 years ago when we published one of the first studies in this area, the Treat for Ramadan study. So I'll be looking at the trial evidence, uh, focusing not on all stride, but some of the major trials, looking at some meta-analysis, and then looking at the positioning of GLP-1 based therapies in recent guidance. Now, GLP-1 therapies are quite interesting because they tend to not only help with controlling diabetes, but also have a kind of a physiological effect on fasting, which when you speak to the patients may offer them certain advantage. So this CGM you must have seen for a long time. This is what happens in somebody who hasn't got diabetes and is fasting on CGM. Blood glucose tend to remain just rise a little bit at the iftar time. And if somebody has got type 2 diabetes, this is the kind of a graph of the rise of glucose levels that happen at the time of iftar, and this is what we are trying to address to try and keep the glucose levels as close to normal as possible. Now, the GLP-1 therapy, or what is now called incretin-based therapy, has really evolved in the last 20 years. It started with exenatide, which was launched in 2005, and then as we can see, it has come to a point where we have got tirzepatide or Manjaro, which has been launched. The molecular structure of these molecules have changed tremendously, and what is in store is even more fascinating. So now all these therapies come under the term novel nutrient stimulated hormone based therapies, which have been developed and in pipeline for obesity treatment, along with most of them being used for type 2 diabetes. So you could see there is a whole plethora of agents from GLP-1 receptor agonists to dual GLP-GIP combination to GLP-1 glucagon combinations, triple receptor agonists of GLP-GIP glucagon, endopancreatic receptor agonist, and oral GLP-1 agonist. And this field is going to get more and more crowded. More and more people will be on these agents. The recent analysis by KPMG has said that the sale of these drugs by 2035 will be nearly 300 billion pounds globally, which means a lot of these agents will be on a lot of patients will be fasting in Ramadan, will be on agents, and therefore we need not only to know about these patients, but we need to do more research to completely understand them. And the reason why it is even becoming more important is because these agents not only have a positive effect in terms of their effect on diabetes and weight loss, But the GLP GIP receptor is probably found in almost all the organs of the body, and this is some of the ways that interact. They suppress the appetite, which is good for somebody who's fasting, especially prolonged fasting in Ramadan in UK, which can be up to 14 to 16 hours. It delays gastric emptying, so you've got a feeling of fullness. It secretes the insulin, suppresses the glucagon, and also causes modulation of fat utilization. Now, if you actually look into some of the recently published trials, it's not only has a positive effect on type 2 diabetes, it offers cardiovascular protection, it offers renal protection. There is the OSA trial, which surmount, which showed that it is even good for obstructive sleep apnea. So these drugs are acting beyond diabetes. So how are they useful in Ramadan? Then this was a old study that actually showed that during Ramadan, the hunger satiety cycle is very much affected because these drugs tend to act on the hunger satiety cycle. So they do offer a beneficial effect. So one of the first studies that we were involved in was the Treat for Ramadan study. It was a very simple design, 1:1 people fasting during Ramadan, randomized to either metformin and liraglutide or metformin and sulfonylurea, and they were analyzed post-treatment. The clean inclusion criteria was a minimum fasting of 10 consecutive days, stable metformin monotherapy or dual therapy with metformin plus sulfonylurea or pioglitazone. And the primary endpoint was a composite of HbA1c less than 7, no weight gain, which is defined as either weight loss or less than 1 kg weight increase, and no severe hypoglycemia at 12 weeks. And what did this study showed? It showed that both during Ramadan and after Ramadan, the patients in the liraglutide group did much better when compared to sulfonylurea groups in achieving the composite endpoint. Sorry. The next study was the Lira Ramadan study. This again was with liraglutide, with metformin and sulfonylurea, and the primary endpoint was change in fructosamine from the start of Ramadan. And this is what the summary of efficacy or endpoints were. It showed a similar reduction in fructosamine, and the liraglutide was associated with significantly greater reduction in fructosamine, HbA1c, and fasting plasma glucose, and significantly greater reductions in weight for liraglutide versus sulfonylureas. Then there was this other study that we were involved with, which was the Lixiram study, in which liraglutide versus sulfonylurea added to basal insulin in treatment in people with type 2 diabetes. And again, in this study, when you look at either the reduction in HbA1c or number of any hypoglycemic episode, the GLP-1 group did better than the sulfonylurea group. This was the other study by Mohammed Hasnain and colleagues, which was a prospective non-interventional study investigation into oral semaglutide. And this again, the key features of the study was that oral semaglutide demonstrated significant improvement in glycemic control and body weight in patients with type 2 diabetes during Ramadan, and patient adhered to dosing instruction and showed more pronounced improvements. And the people who stuck to the guidance that was given had better diabetes control. So what we now have is we have got these agents which are not only effective in bringing down the HbA1c by 1.8%, helping people to lose at least 10% of the body weight, have cardiovascular protections, renal protections, have positive effect on muscle and obstructive sleep apnea. And we have got multiple studies of these agents and there are many more, which actually showing them to have a very good safety profile in Ramadan, help in physiological improvement of glycemia, prevent weight gain. So now what are the challenges of using these agents? This is again a meta-analysis of this, again showing a positive effect in terms of the use of GLP-1s. So the clinical tips are very simple, and the question is asked is whether we should be recommending GIP injectable versus oral therapies. The general recommendation for injections were either it's daily or weekly, and now we are having more and more of these weekly preparations. Is very simple. There is no dose adjustment required, and it can be taken in the non-fasting hours. So if you're taking it on a Sunday, you can still have it on a Sunday. And we know that there is a very good evidence in cardiovascular, renal, muscle, OSA, and even for those who are on daily injections, they can just have it after iftar meal, and that is what the recommendation is. And they've got good evidence in Ramadan. When it comes to the oral agents, the current oral agents that we have, the oral semaglutide, although there are a number of them which are on the way, and we will probably have an expanded guideline at that time. With the oral agents, semaglutide, again, no dose adjustment is really required, although I'll come to this point in the new recommendation later on. But the challenge is the practical challenges because they will need to be taken on empty stomach and food eaten after 30 minutes because of their structure, which is such that if any food is eaten, the outer lining of these drugs can be damaged and they can become ineffective. The practical issues is there are two types of advice if you look into the literature. The one is whether it could be taken early at sahur, so the patient has to get up early, or whether it needs to be taken at the time of iftar, and I'll examine that, and the patient has to wait. And again, it has got good evidence in terms of oral semaglutide in terms of cardiovascular and renal protection, and it also has got the SEMFAST trial. Now, this was published about recommendations, and this is there in the guideline, and this is specifically for oral semaglutide. The guidance says it needs to be started at least 6 to 8 weeks prior to Ramadan to reach an effective dose of at least 7 milligrams. Ideally, we want 14, but 7 if the patient is tolerating. And it's avoid titration 2 to 4 weeks pre-Ramadan and during Ramadan. And if the patient is already on oral semaglutide and the dose is stabilized, it is preferred that semaglutide is taken when breaking the fast after iftar, and then you do your maghrib salah, and then can eat because it needs to be taken on empty stomach. Um, and there might be a little bit of differences. Now we also know that the dosing of these drugs from low notice has changed, and they have come up. All the efficacy is the same. They have come up with the new doses, but the advice will remain the same. So this is a very good thing about what we should be doing when it comes to oral semaglutide. It is take iftar with a small amount of water, have the oral semaglutide, do your maghrib prayer, pray for 30 minutes, and then have the iftar meal. So on that note, I would end my talk and will be happy to take any questions. Thank you.